My name is Rick Merson. I'm a speech-language pathologist from Beaumont Health, Beaumont Hospital, Royal Oak. Been there a long time. I'm also on the executive board of the Michigan Parkinson Foundation, and very, very proud of one of these wonderful seminars that we've had every couple years, and our 70 support groups throughout the state, and you are members of that. Today we're going to talk about communication disorders, swallowing, and nutrition, primarily the latter. And you'll recognize these people that you're seeing now. These are people who have had Parkinson's. They're quite famous, and they continued on with their vocation and their life plans. Each one of them, Janet Reno, Attorney General, she didn't resign from her office. She continued on with Parkinson's. Astronaut. He actually discovered he had Parkinson's while he was scheduled to orbit the Earth, and he went ahead with it. He didn't tell NASA, and he went up and orbited the Earth. He did fine. He did an extra vehicular walking and came back and told them, by the way, I have Parkinson's. They were happy that he completed the mission, and he did it quite well. Just as an example to show you that very famous people from different vocations can carry on with their work. Of course, you remember the Pope, how well he did, and now Neil Diamond is a member of this distinguished group. And we're going to talk today about communication briefly, and then primarily swallowing and nutrition. We have here today two very special clinicians, rehabilitationists from Beaumont. Kathy Roeder is the director of the service program in speech-language pathology at Beaumont and a specialist in swallowing. Before she became the director of speech pathology, she developed and ran, and still to this day works in swallowing, and she's a wonderful teacher, and you're going to realize that. And Mary Osak is here, and she is a registered dietitian, and she's going to talk about the best nutrition plans that you can have, especially with Parkinson's, because she works with Parkinson patients. As you all know, Parkinson's begins to show up about 50 to 60 years of age, more in males. The males are in blue, the ladies are in red. More males than women, but that slope is pretty symmetrical, and it increases, of course, as we get older, the symptoms. But the onset of Parkinson's is in that fifth and sixth decade. We have about 1 million people in the United States who have Parkinson's. Every year, 60,000 new patients are diagnosed with Parkinson's. This is what I used many years ago. I still use a little bit of it, but when I was a speech and language pathologist many years ago, we just viewed Parkinson's as a motor impairment that affect just the speech and articulation and voice characteristics. So we focused on that. And over a period of decades, the patients that I saw in that dark line had four major characteristics that I evaluated and treated for. One was general functional communication ability, and as communication becomes difficult, you tend to fall back on some of the everyday communication skills that you use, like talking on the phone, talking to friends, volunteering, talking to people who come to the house. And sometimes you will function at 10 or 20% of what you were capable of. And we track that. Speech intelligibility, we give you tests to see how intelligible you are in your everyday conversation. It's not unusual that patients who've had Parkinson's for 10, 15 years are only 24 to 30% intelligible. And our goal is to improve that in therapy. We also test the range of the tongue motion because, you know, your muscles become a little bit slower, more rigid, more difficult to get to the point of contact. So we test range of motion and speech power. Everybody notices that right away. You meet somebody who has Parkinson's, their voice is softer. That's just one characteristic, and we measure that. And generally, you'd like to have your voice be at least 60 to 70 dB in loudness, everyday conversation. And patients with Parkinson's for 10 or 15 years will drop back to 50 or 40. And then speech rate. If your tongue can't reach its target quickly, you tend to talk very fast. So instead of saying, good morning, how are you? You say, good morning, how are you? So we measure that as fast rate. Actually, it's diminished range of motion. The red line indicates how well they did after therapy. So after a few decades of treating patients with Parkinson's, we really did quite well. We never got them to 95 or 86% of normal, but we made some improvements. That's how we used to treat Parkinson's. Now we realize that you have to focus on not only the speech and the voice characteristics, you have to focus on language, you have to focus on comprehension, cognition, memory, social, psychosocial communication. So now the job of the speech and language pathologist becomes a bit larger, and as we're going to hear, swallowing. And it's just natural that we would have swallowing problems with Parkinson's. And we began to realize, of course, that the loss of dopamine, that's what Parkinson's is, you've heard that today, the loss of dopamine. Parkinson's is a dopamine depletion disease. Parkinson's is just the name of the guy in 1817 who looked at 7 patients. You imagine that? He looked at 7 to 10 patients in 1817, and he got his name attached to the disorder. He didn't want to. It was his buddy, Jean Charcot, who was a neurologist, who decided to honor him after he was gone. He didn't tell Jim that he was going to name the disease after him. But for these 150 years, we've been calling it Parkinson's disease in honor of Jim Parkinson, who was a surgeon. It really is a dopamine depletion disorder, and when dopamine is lost in the brain, it's not just motor function that we lose. And it's not just sensory function, it's emotional, psychological features that are depleted. So we have to treat it all. We're going to learn today from Kathy a good deal about dysphagia. You're going to hear the words modified barium swallow, and you're going to hear something about a peg tube, and you're going to hear about the chin tuck, and you're going to hear a lot of interesting words that define the nature of the disorder when you have weak or rigid or slow muscles. There are a lot of popular ideas for Parkinson's disease, all of them which offer some help. But as Dr. Danette Taylor said this morning, one treatment technique doesn't work with everybody. So LSVT is not the secret for everything. It helps one aspect. But there are a lot of things, yoga, Tai Chi, exercise, anything that activates your life, your social interaction is going to improve Parkinson's disease. And what you're going to learn, and you have learned already, is that the rehabilitation people work interactively. Once the physicians give us a chance to get to you, we all work together. Physical therapy, occupational therapy, nutrition, swallowing, to help you improve and achieve your life goals. So now it's my pleasure to introduce to you Kathy Roeder.
Hello to everybody you're probably exhausted. You've been listening to people talk at you since the beginning of the day. But we have some things we can do together, and so let's do it. And I think the first thing we should all acknowledge is that we all are on a continuum of something going wrong. As we get older, things change, whether it's motor function, or you're in the grocery store ducking down the frozen food because you can't remember your neighbor's name, or whether you go to eat something and you think to yourself, now why is it stuck in my throat? This is just part and parcel of aging, and it's a little more pronounced when we develop certain disorders, a Parkinson's disease, a stroke, whatever happens to us. But let it not be forgotten that we've gotten this far, and a lot of people haven't made it past 15 or 20 or 30 or 40. So let's always say to ourselves, there's still more left, and we're lucky so far. Dysphagia, or dysphagia, is a swallowing problem. And when I say from head to toe, I mean head to toe because, as you know, it affects everything. It affects what you eat in the morning and how you view yourself in a social context. And it can be worrisome because you're thinking to yourself, now wait a minute. If I don't walk that well, okay, I can deal with it. So I don't remember all the things I used to remember, but you know what? Who does? I can deal with that. But swallowing tends to affect the way we live more than anything else. So what is it? Dysphagia. Is it a disease? Should we call it a disorder? Is it a diagnosis? Of these four, you know what it is? It's a symptom. Dysphagia is a symptom the way a fever is a symptom. It is a symptom of an underlying problem, and there are many people who have swallowing problems, and they range from the child in the neonatal intensive care unit to the adults among us all sitting here, to the people who haven't yet been diagnosed with some disorder that relates to the ability to use muscles and nerves to get food to your stomach. So who gets it? Neurological disease. If we get critically ill, if I get a very bad pneumonia from the flu, end up in the hospital on a ventilator for a while, get off of it, I will find I'm having trouble swallowing because I'm weak. So generalized weakness contributes to difficulty swallowing. And respiratory failure, the vent, or you need a tracheostomy. All of our patients with head and neck cancer, all of them have difficulty swallowing. If I go out and fall down in the parking lot on my head and have a traumatic brain injury and seriously lose consciousness, I will have likely an associated problem with swallowing, with thinking, with remembering words, and with doing all the complex things I want to be able to do. Neuromuscular disease and developmental disorders, including just a prematurity. So how do you explain swallowing? It's pretty easy. Let's do it this way. Everything starts here. Everything starts with your brain. Your brain is the motor control system and the thought control system of the body. Swallowing is what we call multi-centric and multifocal. What does that mean? It means that both sides of your thinking brain have centers for swallowing. The stem of the brain has a major impact on swallowing function, but swallowing also occurs in your mouth, in your throat, in your esophagus. So that's why we call it multi-centric and multifocal. If I say to you, and let's try it, swallow, you just used both sides of your thinking brain to do that. But while you're sitting here, without thinking about it, you're swallowing. Otherwise, we'd all be drooling all the time. So your brain stem is controlling the involuntary, the unthinking aspects of swallowing as well. In a way, the fact that we have so many centers for swallowing is helpful because if something goes wrong, we can compensate using a different function of the brain. We can exercise our muscles for swallowing just the way we can for talking and walking. All of us have a dominant hemisphere, one side of the brain that's the stronger swallowing part. But you know, the problem, of course, is we don't know which one it is. So it's a nice anecdotal piece of information, but it doesn't help us that much. The brain sends electrical signals to nerves, and the nerves carry those electrical signals to muscles, and the muscles contract. And that's all muscles do. They relax, they contract, and that's their whole act. Just to show you a slide, here's all the muscles you use to use your mouth to manipulate food, to form what we call a ball or a bolus, and to push it to the back of your mouth. Everything that you do with these muscles is what's called the oral being mouth, phase of the swallow. So it requires both motor function, sensation, manipulation of tongue lips, cheek muscles to get the food ready to swallow. So if we have weakness, if we all have weakness of our tongue and lips, are we going to have trouble with the oral phase of the swallow? Chances are yes. Can we get better if we have trouble with the oral phase of the swallow? Sure. Sure you can. You can practice chewing. You can practice lip tension. You can practice tongue movement. If you swallow, think about your tongue right now. Where does it go? Kind of up, right? Swallow again, and back. And that back, the back is what's important. That last third of the tongue is what we call the pharyngeal tongue. This part that gets the food actually down the throat. Somebody says to you, pharynx, what does that now? You're already getting confused. Why do you use all these crazy terms? We did not invent these. Somebody who doesn't like people invented all of these terms because they're hard to remember. But if you want to find out where your pharynx is, you can go in the mirror and you can open your mouth. And there it is in the back where you look to see if you have a sore throat. You think, oh, for sure, I'm dying here. My throat is killing me. If I look, oh, look, it's red. And you know those little arches that get really inflamed when you have a bad sore throat, even post-nasal drip? That's where the receptors are for swallowing, so that your tongue pushes the food back and the nerve receptors right at those little arches says, aha, I've got food here, and they trigger a swallow. And that sends the food into the pharynx. And the picture on the right shows you the pharynx. If I don't think I have a pointer that I can use, but if you look where the bones start, at the very top, and you look to the left of it, that is the trachea, all the way to the left. It has a little slit. See the little slit? That little slit is your vocal cords. So when you swallow, you get the food ready, your tongue pushes it back, the receptors at those arches trigger an electrical impulse to send the food into your pharynx. Goes beyond the base of your tongue, all the way down, and when you swallow, your vocal cords close so you don't get food down the wrong pipe, your windpipe. But do human beings get food down the wrong pipe? Yes, we have a design flaw among many. For sure, you go to swallow something and you think, oh, typically water, you're in a hurry, you're standing at the sink, you take a big guzzle, and you find yourself coughing. And you're coughing because your body is saying, excuse me, but I do not want water like this in my lungs. And by the way, I don't like coffee in my lungs either. If you get a little bit of fluid down the wrong pipe, are you going to suffer a terrible fate? No, because we do it all the time. We get food down the, not food, but saliva down the wrong pipe while we're sleeping, all of us. So when someone says, down the wrong pipe is aspiration and it will be the end of us all, the answer is not exactly. If it's happening all the time, if it happens chronically, it can lead to infection. It can lead to pneumonia. But we scare ourselves unduly by immediately freaking out that if we get something down the wrong pipe, we are not going to live. We are. We just want to minimize it as much as we can. Okay, there's a good picture of your oropharynx, and a little part hanging down, and you know is the uvula. Half of us don't have our tonsils because physicians loved to take them out in the 50s. And you can see there's your tongue and your palate. All of those things work together. So let's say you're in charge of evaluating your friend's swallow. And you want to determine whether their problem, if they have one, is significant enough to be a risk factor for developing an infection like a pneumonia. The first thing to know is what's the underlying medical problem? And for all of us here, it's Parkinson's disease, right? That's the underlying medical problem, so we know that. Now, just because we have Parkinson's disease, do we have a history of repeated pneumonia? If we do not, we can put that in the good category of saying, okay, this is not happening. Does it mean it can never happen? We can all get pneumonia. for a lot of different reasons, but not necessarily because you have Parkinson's disease. If you have the ability to exercise, as Dr. Merson suggested, and if you have the ability to work on the strength of your voice, you're working on closing your vocal cords. And when you work on closing your vocal cords, you're helping your swallow function. So there's a lot of ways around the essential design flaw of being a person. If you have a cardiac history, that can contribute to pneumonia all by itself. So lots of times people come in and say, aha, you have Parkinson's disease, and now you have a little bit of pneumonia, but they forgot that there's congestive heart failure in you or your family. And that's really what the issue is. It's not the Parkinson's disease at all. But good vocal strength, clarity of speech, thinking about what we're doing, learning new skills and exercises to combat any weakness we have with swallowing are all the pluses we can use to help ourselves to manage the business of sustaining life through nutrition and eating by mouth. Okay, so you're evaluating your friend. You think to yourself or your spouse or yourself, do I have fairly clear speech? Can I get a fairly strong voice? Can I do an ah and keep my voice going? That shows you pretty good breath support. Can I drink a single sip of water without coughing? Can I drink rapid, uninterrupted swallows without coughing? If I can do those things, I'm pretty good. If I cannot do those things, then speech and language pathology is at your service because we can certainly help to improve all of them. You want to know what the pharynx is in a modified barium swallow. You may have heard it. A barium swallow is what you use to see if your esophagus is doing what it's supposed to do and squeezing the food down. Can you make your esophagus do anything? No, it's all involuntary. But the pharynx, this tube, is both involuntary because we know we're swallowing while we're sitting here, and voluntary because if I say to you, put that in your mouth, that little sip I'm watching you drink your coffee. Take a sip. There she goes. Don't swallow it. There's a voluntary, now swallow. And she did. And no coughing, good job. Okay. So on the modified barium swallow, we try applesauce, we try cracker, and we try thick and thin liquid because those kind of represent the foods we eat. We put a little bit of barium in everything, and we watch on a video x-ray along with our patients and say, is the food going where it's supposed to go? Is it leaving residue in the little recesses we all have? Is it going down the wrong pipe or near the wrong pipe? And what can we do to make things work better when they're not? Sometimes people say, my gosh, I swallow something and it feels like it's stuck in my throat. And this is a perfect example of that. We all have the dark is the food with barium in it. We put barium in it for contrast so that we can see it. And then we say to ourselves, okay, so they have food in the upper recesses and a little food in the lower recesses, and it is an annoying feeling when you're eating. You're like, why? I always feel like there's something stuck in my throat. So there are exercises to work on the constriction of the pharynx just so the muscles squeeze better. There are food consistencies that we can vary, and there is alternating thick liquid with thin liquid, or having a wash of liquid, or getting the food into a state where it's easier to swallow. And Mary will talk all about that. Sometimes we do have food down the wrong pipe, and this is a primary example. See where it says A at the very bottom? A is not standing for associate. It is standing for aspiration. So it means that this particular person had liquid enter their trachea. Some people cough, most of us do. Some people have silent aspiration, they don't feel it. We all know what Parkinson's disease is, we already talked about it. I am laughing at this one comment. It's mostly over the age of 50. Disease to death is 15 years. Well, listen, if we're all 70 years old, that's true for all of us. It has nothing to do with disease. It has to do with the lifespan of the human being. And I say wrong to this slide. People will tell you that you can have a pureed diet. And you think to yourself, it doesn't sound that good. I can have it, but do I want to have it? This is the question. There are many ways to eat foods that are really soft, that don't require chewing if you're really tiring chewing and you can't do it. Because oatmeal with banana and cinnamon is a pureed food. You can smash the banana, you can cut it in tiny pieces. A sweet potato with a little apricot jam and a little nutmeg on the top is a pureed food. Yogurt with applesauce is a pureed food. A thick soup that we like to call a bisque in the restaurant for $15 a bowl is a pureed food. So we say choose a food that by nature is in that state. Lots of people have tried to make a lot of money with slurries and smushing things together and blenderizing them. And who's going to read the cookbook? Who's going to make it? Most of us are not. We're like, we're not cooking. Do we have to start this now? No. You can actually pick things that are by nature pureed and incorporate those into your diet. Does that mean you can never have something you chew again? Absolutely not. I think it is imperative that we do what we need to do to get our nutrition, and we work on the things that are harder to keep our skills. So it's important to have things to chew. It's important to have easily dissolved crunchy solids. There's nothing rehabilitative about staying on the thing you can already do. If I say to you, stick out your tongue, there she did. Now, should we work on sticking out her tongue? She can already stick out her tongue. So lots of times what happens is you go in and you do a therapeutic exercise and think to yourself, why am I doing what I can already do? Why don't I do what I can't do? And the same is true for swallowing. We should always work on the next step up. Maintain what you can to get through your meal, but keep working on the things that are elusive and a little bit hard. Sometimes, and you know, it has nothing to do with Parkinson's disease. Let's say we all had some dementia. We all have a little. We've all lost a few. I went in the parking lot and forgot my car this morning, so who knows what's going on. But all I can say is this. It runs on a continuum with normal. Every loss is part of the loss of a human being. We all have those. But attention and impulsivity sometimes become more pronounced in certain disease issues or in aging. And so those become the issue. It's not the person can't swallow, it's that, my goodness, the bite is too big. Or you're putting too much in at the same time. So sometimes having one thing on a tray, one thing on a plate, is an easier go than having many, many foods that you lose control of. Don't forget breath support. It's very important. So if you feel like you're shallow in your breathing, that's a perfect exercise that you need to do. But all of us have a little trouble swallowing. You ever feed a baby and you think, my gosh, what's the matter with this baby? Because they're coughing and sputtering on their bottle until they get the hang of it. And toddlers with a sippy cup are coughing. The cough by itself isn't the issue. The issue is, what can we do to make a meal easier? What can we do to make a meal more comfortable, more socially applicable, and more fun? Some techniques that people will tell you to use are listed here. A chin tuck only works if we know in a modified barium swallow that it works. But we can't tell everybody who has a problem swallowing to do a chin tuck because it isn't a universal application, any more than, let's say, Lee Silverman is a universal application. If I tell you to stick your tongue through your teeth, go ahead and try it, and swallow, can you do it? Okay, you're exercising that posterior third of your tongue. If you have residue on one side of your throat or pharynx, and I tell you to turn your head to that side, you'll direct it down the stronger side. But we need to see a modified barium swallow to know that. Try this one. Take a breath, hold it, and swallow. Don't let your breath out. You've increased the constriction of the muscles here. Let's try another one that's even harder. You ready? You game? Okay. I'm going to give you the sequence first and then try it. You're going to take a breath like you did. You're going to hold it like you did. Swallow, but you're going to freeze your Adam's apple. As soon as you feel it go up to the lower jaw, you're going to freeze it there. You're going to hold it. Ready? So take a breath. Hold it. Swallow. Freeze. Count to yourself. 1, 2, 3, 4. Finish swallowing. You have increased the larynx's ability to rise, which is important. You've helped with vocal cord closure, which is important. You've helped with the sphincter that's between this tube, your pharynx, and this tube, your esophagus, open longer so that food goes through. And then the Shakir exercise I'm not going to demonstrate because I have to get down on the floor and raise my neck, raise my head, and hold it. And that helps too with the sphincter between this tube and this tube. On a different day, I would do it, just not today. Yes? You want to try it again? Okay. The Mendelssohn was the last one. You're taking a breath. You're holding it. You're freezing it. As soon as your larynx gets to the lower jaw, you're freezing and holding it up there. And most people can't do it that well. And I mean people who don't have a swallowing problem. But we have a new synchrony device, which is a biofeedback device at Beaumont, at the Beaumont Health and Wellness Center on Coolidge and at the West Bloomfield Center. And it is a great device because literally you have electrodes hooked up here and here. It doesn't hurt you. And what you're doing is when you do the Mendelssohn maneuver, you have a kangaroo that's jumping across the screen. Or you have bow and arrow that you're keeping and you're getting coins, or and you get the biofeedback of watching the result of a good technique. Okay, so Mary's going to talk much more about this, and I will say little about it, but remember there are all different ways to keep eating, and that is our goal, is to keep eating. Should you be in a situation where you need a feeding tube or decide that that is the right thing for you, there are very, very few instances where you can't also eat something. You know, I had a patient who had multiple sclerosis, and he was a businessman, and he was quadriplegic. You know, he was wheelchair dependent, a great thinker, a pretty good talker. He had dysarthria, or slurred speech weakness. He certainly had difficulty, a lot of difficulty swallowing. He had a peg tube, and he went out and he ate something with his family too. And he said for him, who had had repeated pneumonia over and over, his decision was, I stay on the planet because I like it here. I'll have the peg tube because it stabilizes my nutrition, and I'll eat a little because it's my social outlet. And he's done extremely well doing that. Sometimes we worry that we're getting the right nutrients, and Mary will talk about it, but sometimes when you're limited or you're sick or you're in the hospital, remember to yourself, half the planet lives on rice. You know, and they make it. So we can't totally freak out about it either. Most of us will survive if we get enough calories, and we will thrive if we have good nutrition. So these are axioms in speech pathology that we live by, and that is this. We say to ourselves, look, we have dysphagia here, and somebody has dysphagia, but we're not going to kill the person by trying a little water. Don't let anyone tell you that that is a terrible thing for you, that you can never have water or ice chips or popsicle or any of that. I say wrong. Yes, you can. We have to do some exercise if you're having severe problems. We may have to limit the size of things. We may have to do it differently, but yes, you can. Neuroplasticity is the ability of the brain to change. And in order for it to change and strengthen, it has to be exercised. So sometimes refraining from doing something means that you don't practice it and get neuroplasticity. Maybe the modified barium swallow, that swallow study wasn't perfect. Maybe it showed residue. Maybe it showed aspiration. That's why you come and you get some therapeutic intervention. That's not the end of the game. That's the start of it. The best treatment plan for all of us always is the one we can tolerate and the one with which we can be the most compliant. Because if we can't do it, there's no sense talking about it. Let's work on something we can do and get better. And thank you very much.
Good afternoon, everyone. Thank you for staying till the bitter end, and hopefully I'll provide some information that you all can find to be helpful. I'd like to talk today about the importance of good nutrition and what is basic healthy eating information for Parkinson's, and then discuss management of different diet issues that are commonly experienced, such as chewing, swallowing problems, unintended weight loss, constipation, dehydration, orthostatic hypotension, and bone health. And then finally, I'd like to mention some various food medication interactions. So as many as 60% of people with Parkinson's disease are at risk for malnutrition. Obviously, the risk increases with increased age for all of us, but in particular with Parkinson's, there's a decreased sense of taste due to the loss of the sense of smell. Various medications that you have to take can cause lack of appetite, nausea, and constipation. And then if you also have additional diseases, depression, or even inability to access food, that can compound the problem. Chewing and swallowing problems occur frequently. Increased tremors can increase caloric needs. And then unplanned weight loss is a serious issue that we'll talk about in a few minutes. The benefits of good nutrition are that you feel better and you have less risk of bone fracture, dehydration, bowel impaction, and weight loss, and also decreased risk of having to be hospitalized for any of these reasons. As other speakers have mentioned, with Parkinson's, there is a slowing down of the GI function, and it affects the GI tract from the top to the bottom. So chewing and swallowing are affected, digestion, as well as elimination. To deal with chewing difficulties, our number one recommendation is small, frequent meals so that you don't tire yourself out by having to eat a long and lengthy meal. Soft, moist foods are recommended, such as what Kathy mentioned, meatloaf, casseroles, ground meat with gravy, canned or cooked fruits and vegetables. And also liquid nutritional supplements can be used to supplement what you're able to eat at mealtime. I'm going to skip over the swallowing problems, but I do want to focus on when does weight loss become an issue or a significant problem? And this is what dietitians and doctors look at when determining whether or not a patient is at risk of malnutrition. If a person has lost greater than or equal to 5% of their weight within 1 month, greater than or equal to 7.5% within 3 months, or greater than or equal to 10% within 6 months, this is considered significant weight loss, and interventions need to be taken to prevent any further weight loss. This slide is kind of cluttered, but it basically gives you some suggestions for ways to increase calories and protein in the foods that you eat by adding extra fat and or sugar to foods, adding extra protein in the form of cheese, eggs, nut butters, protein powder, and the use of commercial liquid nutritional supplements such as Ensure or Boost to supplement your intake. Kathy covered the treatment for dysphagia, and just a little bit more detail, after you have a swallow evaluation or a modified barium swallow, the speech therapist may recommend that you change the consistency of either your food and or your liquids, and some of the varieties of changes may include pureed or mechanical soft or soft foods, thin liquids, nectar thick or honey thick liquids, because as a general rule, thinner liquids tend to go down the throat rather quickly, and they're more difficult to control if you have weak swallowing muscles. If your speech therapist does recommend that you thicken your liquids, I was asked to talk about where you can purchase food thickeners, and these are readily available you can order through any Gordon Food Service Marketplace store in the metro area. And of course, there's always Amazon.com to order things like this. And the directions for how much of the thickener to add to various liquids will be right on the label of the container. If you are having increased tremors, sometimes it may cause difficulty with the physical aspect of eating. And so sometimes adaptive eating utensils are recommended, and an occupational therapist would be the best person to know what would be appropriate for you. But it may include using weighted utensils or scoop sort of dishes, two-handled cups, etc. And again, these items are readily available through Amazon.com. Constipation is a very common problem. One of the speakers today said it occurs in 80% of patients with Parkinson's, and its technical definition is having less than 3 bowel movements per week, and it's caused as a side effect of some of the Parkinson's medications, but also the disease process itself causes a decrease in peristalsis, which is the movement of our food through our stomach and intestine and colon. It can become a problem if it goes untreated and leads to something called fecal impaction, where the person may actually have to be, the stool may have to be manually removed. And you'd want to try to avoid that if at all possible, obviously. So the primary treatment or prevention for constipation is fluids and fiber. And fiber is recommended in the amount of 20 to 30 grams per day. Fiber comes from plant foods, such as whole grain breads and cereals, cooked dried beans and lentils, fruits and vegetables, especially if you can eat the edible skins. It is important, if you're not used to eating a lot of fiber in your diet, that you add it gradually to your diet and make sure you're drinking adequate fluids along with the fiber, because otherwise the fiber particles remain dry and they can't do their job of bulking up your stool. And sometimes people tend to get sort of bloated or uncomfortable if they're not drinking enough fluid along with their fiber. Again, you can get fiber from 3 servings a day of whole grains, 2 cups of fruit a day, and 2.5 cups of vegetables per day, a minimum of 64 ounces of fluid. Legumes, nuts, and seeds are all high in fiber. Prunes and prune juice, and there's even a recipe for what's called a prune juice cocktail, which can be taken like a couple tablespoons per day. You keep this in the refrigerator. Regular exercise also helps constipation because it strengthens your abdominal and your pelvic muscles. You can also ask your physician about stool softeners or the use of fiber supplements. Dehydration is a common issue for all of us as we get older. Our thirst mechanism, where our body tells us when we're thirsty, it actually decreases with age. And this can lead to increased risk of constipation and urinary tract infections, because adequate fluid is important to flush out any harmful bacteria in the bladder, and therefore it's necessary to drink adequate amounts of fluid. Some signs of dehydration may include dry, sticky mouth, headache, personality changes, dark urine rather than pale yellow urine, dizziness, things like that. And in order to tell if you're getting enough fluid, as I mentioned a minute ago, your urine should be a pale yellow color, not dark. And a rough recommendation for how much fluid we need is to take your body weight in pounds and divide it by 2, and that's the approximate number of ounces of fluid you should aim for each day. In general, you should aim for 1.5 to 2 quarts of liquid a day. And sometimes, since we lose our thirst mechanism, it might be necessary to almost treat fluids as important as taking your medications, where you kind of schedule drinking your fluids, where you take a glass of water first thing in the morning and then take your daily medications with a full glass of water as well. If the taste of plain water is a turnoff for you, some recommendations are to add natural flavors such as fresh lemons or limes or oranges, cucumbers, mint leaves, or fresh ginger root to make the water more tasty. Try to keep a water bottle with you throughout the day if you're out and about and traveling away from home, and keep it in your car so you remember to take sips throughout the day. Try to replace soda, juice, and coffee with more water as your primary source of fluid. Orthostatic hypotension can occur in up to 50% of people with Parkinson's, and it refers to a drop in blood pressure when you stand up, and that can cause lightheadedness or dizziness. Of course, your doctor may change your medications or your Parkinson's meds or your other medications that you take to deal with this, but in terms of manipulating your diet, it may be helpful to avoid large meals. So again, small, frequent meals are usually recommended. Increase your dietary salt intake or salty food intake. Increase your fluid intake to that minimum of 64 ounces per day, and decrease alcohol intake. Bone health is important for all of us as we get older, and these are some recommendations to help prevent osteoporosis. You want to maintain a healthy weight. Discuss with your doctor any diseases, other diseases that you have, or medications that you take that are known to increase the risk of osteoporosis. It's helpful to avoid smoking, excessive alcohol intake, and inactivity, and get adequate calcium, vitamin D, vitamin K, and magnesium in your diet. Regular weight-bearing exercises help to stimulate bone growth, and examples would be walking, hiking, jogging, tennis, dancing, things such as that. Calcium, the amount that's recommended per day is 1,200 milligrams for adults ages 50 and over. Of course, we all know about milk and dairy products being good sources of calcium, but it can also be obtained from dark green leafy vegetables, canned salmon or sardines from the actual small edible bones that are in them, and tofu if it's prepared with calcium, and almonds. And I need to backtrack a little bit. Calcium is important to help your body absorb vitamin D. I'm sorry, I've got that the wrong way around. But calcium-fortified foods are another option if you don't care for dairy products. You can find orange juice, rice or soy milk, or breakfast cereals that have been fortified with extra calcium. Okay, so again, vitamin D helps your body absorb calcium, and our body is able to produce vitamin D through exposure to sun without, like the unprotected exposure to sun without sunscreen. But some people nowadays are concerned about the other risks of exposure to sunlight, and we all live in Michigan and don't get much sun for most of the year. So it may be necessary to take a vitamin D supplement. You can talk about it with your doctor. The recommended level of vitamin D in the blood for patients with, or I should say persons with Parkinson's, is 40 to 60 nanograms per milliliter. And that's according to a Dr. Duda, who's involved with Parkinson's, a Parkinson's center in Pennsylvania. You can also obtain some vitamin D from cheese, butter, margarine, fortified milks, and fortified cereals. Vitamin K and magnesium are also important minerals to help build strong bones. Now I'd like to switch over to some of the food medication interactions that can be a little bit tricky. When we eat foods that are made from protein, they're digested and they're broken down into their basic building blocks called amino acids. However, levodopa is also what it's called a large neutral amino acid, and it also is absorbed in the small intestine and then transported to the brain, the same as the amino acids that we get from food. So if you eat a high protein meal at the same time as taking your levodopa, the food amino acids are going to compete with the levodopa for absorption. And for that reason, it's recommended to take your carbidopa, levodopa, 30 minutes before or 60 minutes after your meals. If you take vitamin supplements that contain iron or iron supplements by themselves, you also need to take them separately from your levodopa by at least 2 hours. Some people with advanced Parkinson's disease develop motor fluctuations that may benefit by what's called a protein redistribution diet. And you would want to discuss this with your doctor first before you attempt it yourself. And it may be helpful to ask for a referral to a registered dietitian to help plan out the actual nitty-gritty of what to eat. But there's 3 basic methods: the balanced protein plan, where your daily protein requirement is divided equally among all 3 meals; the evening protein plan, where you save your high protein foods and eat them only in the evening to allow greater mobility during the day; and a plan called the 7-to-1 menu plan, which consists of meals that are 5 to 7 parts of carbohydrate for every 1 part of protein. And this slide gives you some details about that type of protein redistribution diet. In general, you're eating very small, like 1-ounce portions of high protein foods, along with large servings of fruits and vegetables and grains. And actually plant proteins like legumes and lentils and nuts and seeds naturally have this sort of a ratio, so they are a good choice for this plan. There are details about this sort of diet in a book called Eat Well, Stay Well with Parkinson's Disease by Catherine Holden, who is a registered dietitian who's very well versed in working with persons with Parkinson's disease. And you can order that through Amazon. Just to mention about MAOI inhibitor medications, Aldapril is the brand name of one of them. If you take more than 20 milligrams of Aldapril per day, it is necessary to avoid foods that are high in tyramine. And basically, those foods would be aged foods or fermented foods, and they're listed for you on the slide. So to end my presentation, I'd just like to talk a little bit about the fact that there is no one recommended diet to help prevent or cure Parkinson's disease. But in general, most chronic diseases nowadays, there's been multiple studies done to show that the root cause of most of our diseases, like diabetes, heart disease, cancer, obesity, and even neurodegenerative diseases, such as Parkinson's, are due to what's called inflammation. And inflammation is a natural process in our body. It's a reaction to injury, whereby, like if you get a cut on your finger, you have redness or swelling as the blood is shunted to that area to help bring white blood cells and healing substances to that area. And ordinarily that helps us to heal. But if people have chronic inflammation or excessive inflammation going on in their body, it's thought that it contributes to these chronic diseases that we see so much of nowadays. So in general, an anti-inflammatory diet, and a good example of an anti-inflammatory diet would be the Mediterranean diet, just so you have a basis to look at. These diets are high in fruits and vegetables because fruits and vegetables contain antioxidants and plant chemicals that are very protective against inflammation. This diet would be low in saturated and trans fats, but high in omega-3 fatty acids, which come from fish. It would be limited or eliminating refined carbohydrates and sugar, increasing whole grains, beans, and legumes, reducing your intake of high-fat animal proteins, avoiding refined and processed foods, eating more what we call whole foods, adding healthy herbs and spices, drinking water and tea, and maintaining a healthy weight are all considered part of an anti-inflammatory diet. And it's not on here, but also it's important to get adequate sleep to decrease inflammation in the body and to do regular physical exercise or activity. So I thank you for your time and attention, and I think at this time we're going to open it up for a few questions.
We have one question back here.
I have never heard any reference to hearing at any of the Parkinson's seminars I've been at. Is there any association between Parkinson's disease and hearing? And then as another question, vision.
What?
Yeah. Is there any association with hearing and visual loss with Parkinson's?
No, not hearing. Loss of hearing is not associated that I know of with any of the medications. There are some ototoxic medications, but primarily antibiotics, mycin drugs, and vision. No, not to my knowledge.
I think they're tired. All right, we are good.
Okay, any other questions?
What about vision? Vision? Vision. He mentioned vision also.
She wants to know about vision also.
Alzheimer's disease?
No, vision. Problems with between Parkinson's and vision.
And vision. I don't know of any association between poor vision and Parkinson's disease. I mean, you may have poor vision because of symptoms associated with aging, but not with Parkinson's. The Parkinson's does not cause increased pressure, glaucoma, doesn't. Not to my knowledge.
We have a question over here.
Well, just when not to counter what you said about vision with Parkinson's, but my husband when he went to get new glasses, he had blended trifocals and he doesn't like them as his Parkinson's advances. And the tech in the ophthalmologist office said that he had a number of people in with Parkinson's who did better with lined bifocals. That line is a division, just like when you walk with Parkinson's, you've lost that ability. You need that line to walk over or your brain to.
Sure.
So he's wearing them now. Are you doing well?
Well, that's an
Anyway.
interesting point.
Yeah.
I'd leave that up to the ophthalmologist, but that getting a bifocal so you could look down and get an image of your foot moving forward,
Right. It's a big.
that would be helpful in,
We recently
Movement.
found a neuro-ophthalmologist, which I never knew
Oh.
existed.
that's very good.
There is one with the Henry Ford system.
Uh-huh.
I'll even say his name, Dr. Scarf, whom my husband saw.
Uh-huh.
And he said that people with Parkinson's cannot use the progressive lenses. So maybe the divided lens for a bifocal works, but he prescribed for my husband a reading glass with a prism in it so that it will help him read and follow along on the lines much better, and that people with Parkinson's have trouble with progressive lenses. I have a
Okay, I accept that. That's very
progressive
interesting.
trifocal, and I get along really well with it, but Gene had bifocals and it didn't work. So each one is different, but that's what this neuro-ophthalmologist
Sure,
taught us.
well, I would defer to him. Absolutely.
Okay, any other question? One right here.
When I went to see my neurologist the first time, he indicated that I rarely blink. And of course, there, again, is dry eyes. And my bifocals are not near as effective as they have been in the past. I get new glasses and I still can't see as well as I used to. And sometimes I find myself looking over the top at my glasses to look in distance. So it has done some effect for sure.
Interesting.
Okay, one more over here.
I just have a question about the swallowing. My mom aspirated in the hospital, and they immediately put a feeding tube in and said that's what she has to have. Never did any swallowing tests or anything. So if this happens, should we insist that we get swallowing tests or something, further on? I think they just looked at her and she was older, so boom, done, because they're on their way out. It's, I think, a lot of people's attitude.
I think you should always just ask. I want a speech pathologist, and I want an evaluation of swallowing, not just bedside, but I want the swallowing study. I want the one where you can see on a video x-ray how she swallows. I think it's important because lots of times we draw conclusions about what we think we know on the basis of what we think we see, but you really can't judge if someone is very, very sick and cannot lift their head off a pillow or talk. At that point in time, you kind of have a good answer that they aren't swallowing too well. But to try to plan long-term without a swallow study is probably not as efficient and not as reliable. So I would always ask. Sure.
Okay, is that it for the questions?
We got one more?
One more? Okay. Roseanne.
Okay, I'll stand up.
Of vitamin D recommended for?
Here you go.
The recommended blood level of vitamin D, like a healthy vitamin D level, would be 40 to 60 nanograms per milliliter. Okay.
One more time, she said.
40 to 60 nanograms per milliliter. Okay, thanks.
My husband died as a result of a swallowing accident, having Parkinson's for 22 years. And my recommendation is, because he took a piece of beef at a meeting where there was plasticware, didn't cut his piece, and before he literally died, but he was brain dead and lived 2 weeks on, everything else. But my advice to, as I coordinate a Parkinson's support group, is always carry real silverware in your purse so you can cut meat into small pieces to avoid that kind of accident, because he wanted to take a bigger piece and not make a fuss. But you need to be cautious, and I know my children, they tell anybody that has Parkinson, always carry some real silverware so you can cut meat into smaller pieces so you don't experience that big piece going down your throat.
I'm sorry to hear it. We can choke. Well, that's what people say. That is what choking is. Coughing on food is not choking. Choking is when you don't have an airway. You literally have it blocked, and you can't make a voice. That's why if someone is coughing, at least it is somewhat, a little bit reassuring that they have voicing, and there's not something lodged so that the vocal cords are totally blocked off, because that's when you get nothing. Now, if somebody had done the Heimlich, he couldn't cough it up. And then the other thing to remember is if you have somebody who has a severe problem with swallowing, like that, a very significant problem, that's why it is nice to have a softer, moister consistency, but also shredding meat. Because if you cut it in a little piece, but the little piece occludes the airway, it's why hot dogs are bad foods for everybody, because that bite of the hot dog can totally conform, especially in children, to the size of the trachea. And if it gets there, it's literally like a plug. So I always say cut it in thin slices, almost translucent, because now you've broken down some of the fiber and you don't have a piece. If that makes any sense. But I am sorry. I am really sorry to hear it.
I have a question. What kind of natural fiber supplements or stool softeners would you recommend for constipation for Parkinson's?
Did you say natural fiber supplements?
The most natural ones, yeah.
I always recommend food first. That's kind of where my recommendations go. So the foods that I listed, as far as fresh fruits and vegetables, whole grain breads and cereals, legumes, but you can certainly ask your physician for a fiber supplement recommendation. Okay. Yeah, I don't know any particular brands that are better than others. Yeah.
We were just at the gastroenterologist in Ann Arbor this past week, and my husband had a terrible problem with constipation, and he suggested Miralax twice a day, a whole capful, once in the morning and once at night, and then Benefiber once a day, sometime in the day. And lo and behold, it worked.
Good to know.
I like Miralax myself. I think it's a natural, it's not harsh, it's easy to take, it's prescribed for children and adults, but I would always check with a physician just to make sure.
All right, everybody, I think we are going to wrap it up. It's been a very long day. Thank you very much, all of you. Very wonderful, good information that we all need to know. Thank you so much.